All right. So everybody knows me and Aaron, I think probably. Today we have Nathan Caranda. He's coming on today to talk about bridging psychiatry and recovery. And some of you may know of him from Your Path and all those fun things if you're involved with the town's programs. So next slide.
We have lots of great talks coming up. We have Cole Perringer and Kurt doing a talk on implementing low barrier MOUD in the emergency department. And I'm really interested to hear on June 25th, Anna Solmeyer's Opioid Settlement Fund dashboard talk. I think it's kind of a question mark for all of us. Where are our county settlement funds going? And if we aren't at the table for those discussions and to advocate for our patients, how do we join those talks? So lots of good stuff going on with upcoming echoes. And then please check out the other echoes listed at the bottom of the screen if you are seeking out more CME.
Yeah, now the talk on the 11th is about the hepatic stuff. And this is something in our office we just talk about all the time when we get patients. And it's like, can you give them naltrexone? Can you give them Suboxone? Can you give them all these things? And what are their liver functions? So after all that talking, then Alex is putting together a talk. So we'll see. We'll see. So remember, there's free CME. Just make sure you answer the stuff when it comes from Katie. Please feel free to turn on your video. All of our speakers, like Nathan, love to see people's faces and not the black boxes of the COVID epidemic. We would just soon move past that.
Just a reminder, we're always there for technical assistance needs. If you want to run something by us or if you have needs for policy and protocol, don't reinvent the wheel. Give us a jingle first, and hopefully we have something that we can send your way to use as an example.
All right. And remember, there's you already said that one. Never mind. The core.
Nope, I didn't. But
oh man, I'm all messed up.
Website if you need it.
Yeah, there's a website. You need to find something. Go to the core, and there's all kinds of stuff there. So, with no further ado, we will let him introduce himself, our speaker today, and then he's going to share his own slides. Really thank him for coming. This has been in the works for a while. So, thanks again, Nathan.
Yeah, I appreciate the introduction, and I'm incredibly happy to be here as well. Is it sharing okay?
Looks perfect.
Cool. Awesome. So my name is Nathan Caranda, psychiatric mental health nurse practitioner. And just to kind of give you a little bit of background on me, I actually started out as a paramedic. I worked in Minneapolis at Hennepin County for about 6 years, then transitioned into a role as a registered nurse in child and adolescent inpatient psychiatry. And from there, landed at Your Path as a psychiatric mental health nurse practitioner. Substance use disorder recovery advocacy has always been a huge part of both my personal and professional life. I actually identify as somebody in long-term recovery, been sober for about 16 years and lost a loved one to an overdose many years ago as well. I'm on the board of directors of Steve Rumler Hope Network and Randy's House, which are two recovery community organizations, and then founded a nonprofit that is heavily involved in deflection and diversion work, both here in Minneapolis and then internationally as well. We have programs and projects going in Kenya and Italy. But what I would like to talk to you about today is, sort of the experience that I've had at Your Path with bridging psychiatry, recovery, leveraging peer support, some of the pathways that we've identified, challenges, and progress along the way. So for those of you who are not aware of Your Path, it's a community-centered organization. We're focused on bridging addiction medicine, psychiatric care, recovery services for at-risk and justice-involved individuals. And we do that by partnering with treatment centers, recovery community organizations in order to provide stabilization, care navigation, and that system level support. A lot of the way that we do that, currently is through point solutions like direct care, but ultimately the goal is to leverage a technology platform, which is proprietary to us called SALA, which is a communications hub that connects existing resources within the community together in order to create essentially a care ecosystem for those, because we're aware that behavioral health care is often fragmented or absent in a lot of the conditions or settings that we're treating in. I arrived at YourPath a little over a year ago. At the time that I got there, we didn't actually have a psychiatric practice in place. Dr. Steve DeLisi is our medical director, and he had been working on getting that going prior to my arrival. So as I stepped in, I would say probably within 30 to 60 days of me getting there, we started seeing patients. And I'm not somebody who necessarily works directly in addiction medicine, and that's not because I don't have a comfort level with it. It's not because I don't want to do it. I just luckily work in an environment where there's a lot of collaborative work and practice between both our addiction medicine providers and our psychiatric providers. And so, have been lucky to be in an environment where that's just baked into the everyday care model for us. And so started delivering psychiatric care in basically one of three different settings. The first one, which is the most predominant, is rural jails, and that comes directly out of a grant that we received called MNRAP. Beyond Brink is a recovery community organization. If you guys don't know who Beyond Brink is, I would highly encourage you to do a little research, look into them. It's a wonderful recovery community organization. I've had nothing but positive interactions with the peers and leadership at that group. And they're actually the ones who hold the grant, the MNRAP grant. The aim of that grant was to create rapid access to addiction medicine, the peer support services, and holistically treat individuals who are either currently incarcerated in rural jails or newly released. We currently have relationships established with, I think, 6 jails at this point: Traverse County, Martin County, Crow Wing, Cass, Blue Earth, and talking to Anoka as well. The second setting that I'm practicing in right now is primarily residential treatment. That's usually in person, but those patients or that particular patient population actually really mirrors that first group, as the vast majority of individuals who I'm seeing are justice involved. And that can mean multiple episodes in jail, recently released from prison after 30 years. But, by the time that I see them, they're usually 1 or 2 days out of being locked up. And then community referrals. And so that's just folks who have found our number, directly, trying to get access to psychiatric services or addiction medicine, internal referrals that are coming from addiction medicine, or referrals from other community partners that we don't necessarily have a formal relationship with. And so through those interactions, I've recognized anecdotally some system realities. And I'm going to focus a little bit on the correction system right now, just because that's where the bulk of my work has come. And what I've recognized is that, care in these settings is often reactive and crisis driven. I would say for the vast majority of locations where, I'm providing care, when people are referred out, it's usually when there's some sort of major safety issue, whether that be safety to that particular individual, safety to a staff member on site. The infrastructure varies widely from site to site. And by that, I mean, we can look at the infrastructure within that particular rural jail. That can be anything from, what medications are allowed in a particular formulary. How does administration view mental health and substance use disorder? What is the elected sheriff? What's his or her thoughts on, harm reduction and what should or should not be allowed? And psychiatric symptoms are frequently left untreated or not treated at all. And I will say that, I want to just pause here and offer a digression or disclaimer that all of the interactions that I've had with the jails that I'm working with have been positive. And this is not an indication that I'm throwing shade at any particular organization about what is or isn't. I think that there is a lot of insight into what's needed from the administration at all levels. And there's the recognition that these services are needed. There's just a lack of resources available in order to meet those needs and the goals that those individuals, have set for themselves. And so, what I've seen predominantly is excitement about, getting engaged and having, access to both psychiatric services, addiction medicine, and also peer support. Those addiction medicine and mental health services, which I'm sure we're all familiar with, are siloed, just like what they are in most other areas. And trauma and severe mental illness really shape how people engage with care. It shapes the way that that person engages with me. It shapes the way that that person engages with administration. There's the relationship that I have with administration. There's the relationship that I have with that patient. And sometimes that can be a really complex sort of like triangulation of relationships that need to be navigated in order to really, provide that comprehensive care for that person. And so what ends up happening is these individuals cycle through these systems without any sort of sustained treatment. We'll present a couple case studies here in a minute, but there's often missed opportunities for diagnosis and stabilization while they're incarcerated. And I have had multiple reports of individuals stating that lack of psychiatric care directly correlates with continued use and then ultimately recidivism. So the first case that I wanted to talk about briefly was a 32-year-old male. He was arrested. So I met him when he was in jail to do the psychiatric evaluation. He was arrested on a possession charge. He had endorsed having, positive home life, just happened to get involved in drugs and alcohol in early adolescence. That transitioned to methamphetamine use beginning at the age of 17 years old. And from roughly 17, 18 until the time that I saw him, he had said that he believed he had roughly about 30 legal incidents that resulted in some sort of episode of incarceration for some period of time, mostly in county jails. I had a prior inpatient diagnosis of schizoaffective disorder bipolar type and had reported that he was previously stable on quetiapine. At the time that I saw him, he was endorsing auditory hallucinations, command auditory hallucinations. He was having thoughts of suicide that were passive, not active. And I had asked him during that appointment if he, wanted to get involved in peer support services as well, which he initially denied. We restarted the quetiapine. I saw a rapid reduction in his psychotic symptoms. That stabilization led to us building a little bit of rapport. That rapport led to him agreeing to connect to a peer support specialist. That peer support specialist helped the relationship between he and I. And we all continued to follow him through his episode of incarceration in jail. Peer support helped him connect with me after he was released. He got set up in the community with housing. He was able to start his own sobriety group out in the community. And then eventually peer support helped me connect him to a long-term psychiatric provider that would provide longitudinal support for him moving forward. And to the best of my knowledge, he's still doing well. And so, I think that, while that initial interaction wasn't necessarily focused on, addiction or addiction medicine, it was the building rapport through psychiatric care that helped facilitate that conversation eventually. And then it was the peer support that kept him connected to me and also helped him stay connected in recovery and find the resources that he needed for that continued stability. The next case is somebody who was 29 years old, and this individual I saw at one of the residential treatment centers, which I'm providing care at. She had an incredibly complex trauma history, significant abuse growing up from her parents, and that unfortunately transitioned into intimate partner violence, later in life, and had stated to me, I should say that she was referred to me because she wasn't engaged in treatment. That before, and indicated that those voices were degrading, often encouraged her to harm herself. It fit with the flat affect, the avolition, the low mood. And I had been sober for about 7 months prior to me sitting with her for the first time. And during that period of sobriety, those symptoms had only gotten worse for her, which she correlated with sort of like the issues that she began to have during group. Diagnosed her with schizoaffective disorder, depressive type. We started her aripiprazole. Again, a rapid reduction in her psychotic symptoms. Her mood had improved. Fairly quickly. I would say within the first, 2 weeks, I saw her affect brighten. She started re-engaging in groups, building peer relationships. Within somewhere between 30 to 45 days of me initially seeing her, they actually stepped her down out of residential treatment into her own independent housing where she would attend programming during the day. And so that first psychiatric contact led to that stabilization. Again, not necessarily the path that we initially think of when we're thinking of sobriety and recovery, but, got to me. We were able to identify that she was struggling psychiatrically. That led to stabilization. That led to greater sort of focus in the recovery engagement, and hopeful for the future. And I know she's doing well as well. So so I think from the takeaways that I've had with this work is that psychiatric providers, and I'm not saying just psychiatrists, psychiatric nurse practitioners, physician assistants, but really anybody who's providing any sort of psychiatric care plays a crucial role in the evaluation and treatment of co-occurring disorders, even without providing necessarily that direct addiction care. I think that last case was a perfect example in the way that, yes, I may have been the first person that she endorsed auditory hallucinations with, but I'm certainly probably not the first medical professional that ever laid eyes on her, right? And being able to build that rapport, have an honest conversation with her, encourage that readiness for her to endorse those symptoms with me, not only helped the underlying psychotic and mood disorder, but it also helped her re-engage in recovery. And what we're after at the end of the day is not just sobriety, but it's recovery. And finding ways to give people the best possible chance at life, where they're not just surviving, they're thriving, right? In those moments. Many patients, I think, in these at-risk populations only receive psychiatric care after long delays. Sobriety can reveal psychiatric illnesses that were often previously masked. And so I think there's, opportunity for us to explore that in every interaction that we have with our patients. And I also believe that recovery is possible without perfect systems, right? None of these systems that we're working in are perfect by the definition of what we might define as perfection. But, even if they're a work in progress, I think if you have the right people in place, you have the right aims, you can really see people continue to get better, both on the sobriety side of things and also psychiatrically as well. And I can't say enough about peer support and their role in care coordination to improve outcomes and build trust. I 100% would not be able to do the work that I'm doing without peer support services, period. The interactions that I have are positive within the correction system and residential treatment, but peer support has really been the glue that sort of like held that person in place for me. So they may leave my office, but that peer support specialist is doing that outreach on a regular basis, keeping them engaged with me, and then helping them get to the providers that will eventually help create that sustained stability moving forward. And so psychiatric care is essential in those recovery spaces, even when addiction medicine isn't, concurrent. That peer support and care coordination are crucial. I never thought I would be doing any sort of corrections work, justice involved work, but it's been a patient population that I've really come to know and love. I think over the last, 6 to 9 months that I've been actively involved in it. These folks need and deserve the same level of care that everybody else does, bar none. And, hopeful to see Minnesota begin to continue to improve access for these individuals for psychiatry, for addiction medicine, and really whatever else they need in order to live the same type or quality of life that we all do. And always have believed that recovery is possible when the right supports are in place. So thank you.
Well, maybe what we'll do is we'll open this up to some questions. And, my first question to you, Nathan, would be, why is it taking so long for this type of service to develop in Minnesota? I mean, when I saw you guys show up, it was like, why hasn't this been done, right?
Yeah. Are you speaking specifically in the corrections work or just like in general with everything we're doing?
In general, in general, the kind of service that's bridging that has so badly been needed for so long, especially rurally.
Yeah, it's a good, it's a question I don't have an answer to, Dr. Define. In the way that I agree with you, and I ask myself that question, I think on a regular basis. I've been awestruck by the lack of resources in some of these communities, and a bit ashamed that I wasn't aware that there was that big of a gap in care, and really seeing folks. It's hard to see people struggle. It's hard to see people who care about people who struggle, who recognize that those resources aren't available and don't have the capacity to provide them, right?
Yeah.
And that's challenging. I remain hopeful because there are organizations like Your Path or Stratus that, are stepping in to fill those gaps. I do think, specifically when it comes to the corrections world, there's a lot of room for improvement. And I would love to see like a statewide RFP go out for addressing all of it. There should be a psychiatric provider in every rural jail. I honestly just like the amount of complex trauma, severe mental illness, addiction. I don't see how that's not a thing that's required. And many of these environments that we're working in, there isn't even a staff nurse on board, right?
Yeah.
There's nobody that exists there. So, I think that it's a much larger problem than, Your Path is capable of taking on in that degree. I think that I would just love to see, I would love to see that something come out of that. So
100%. I agree with that. Oh my goodness. Nathan Mindy asks in the chat, how are you utilizing peer support with patients that don't have engagement with SUD services?
Don't have engagement with SUD services in the way that they don't need SUD services or just haven't necessarily had the opportunity to be engaged with peer support.
Peer recovery isn't billable unless there's a comp assessment that recommends it and it's a treatment plan and they're billing underneath an LADC. That's one of our challenges. We have peer recovery people and they're awesome, but they can't go into the jail and bill it unless there's an SUD. And so our SUD assessment and it's recommended. So I think that's one of the barriers when we're talking about this because, Aaron says, yes, they are. So are we talking peer support or peer recovery, I guess? Because peer recovery is SUD specific, peer support is mental health.
Yeah, let's say peer recovery. It's been so, how we're getting around it right now is through the grant. So this is a grant supported program, right?
Okay.
I mean, I think going back to sort of the answer that I gave to like that first question is there's a lot of work to be done to support those types of services. But I mean, I have had, I love working with peers, absolutely do. They've been fantastic in just building those relationships and maintaining it. And we have a whole workflow together where, we meet regularly, follow up. It reminds me a lot of almost like an IOP type of situation where, you have these disciplines sitting together at a table, like figuring out what's best for this patient and then helping navigate them, back and forth.
Nathan, would you mind sharing contact info in the chat? Julie is asking how to get a hold of your remote services.
Yeah, for sure.
And then Jody asks, do you think having more ACT teams in communities could help this problem? My understanding for some rural communities is that the ACT team is only available for patients diagnosed with an SMPI like schizophrenia or severe MDD with psychosis, not substance use disorder, but seems like that could help this population.
Yeah, I mean, I love ACT teams. I think they're phenomenal. I think that, and I want to put a little disclaimer on this, right? Like so much of this is anecdotal, right? Like the experiences that I've had personally. And I believe that information is important. I'm not trying to dismiss my own experience, right? But just wanted to sort of clarify that. And within the context of my experience, so many of the folks that I have seen, and it just could be by way of the fact that they need to see a psychiatric provider, have some sort of a severe mental illness, right? And a co-occurring substance use disorder. I think that ACT teams are, fantastic. I think that, that could be one way to address the issue. I also, when I think of the jails that I'm working in, like, honestly, it only needs, the 6 that I'm in are small enough to where it only needs maybe one psychiatric provider to provide that care. I would love to almost see, counties kind of group together in order to find the funding to maybe, implement like one, person that can cover those, that capacity. I am not going to sit here and pretend to tell you that I know the solution to address mental health crisis in the correction system in Minnesota or substance use disorder, right? Like, I'm not. What I will say is that there's a problem, and I don't know that all of us consider that problem as regularly as we should. And I would really like to see a push at that state level to make some significant changes.
Yeah, some of us maybe think about it way too much, and that's part of our problem, Nathan. I don't know, because it's just one of those problems that begs to be solved. But man, the barriers, So, like when you're doing some of the jail work, and you've got somebody who's withdrawing from a substance, but there's not available treatment for that in that jail, how do you deal with that?
Yeah, that's a good question. I think that, that whole withdrawal management is a whole different game. Yeah. And when I am seeing them, that's not part of the clinical picture, that we're past that particular time, right?
Okay.
I will say as a caveat that, or as an add-on to that doesn't really answer your question, but it sparked an idea in my own head here is that sometimes I feel like it's easier to build relationships with the administration when you're talking about mental health and psychiatry and not substance use disorder, right? Because the SUD is still stigmatized in some degrees. And I have found that, maybe by initially providing some psychiatric services where, there's like informed care in addiction medicine. It's a way to kind of like open and crack that door open a little bit, and then find your way in to have a larger discussion about how do we really bring SUD services into this facility.
Other questions for Nathan? Go ahead.
Yeah, Amy put in the chat, counties could consider using some of their ORF funds to support these services in jails. And ORF, I'm thinking you mean opioid relief funds. Yes, that's definitely something that you could request to use settlement funds for, and it would be, a great resource to have. One of the jails or a friend of mine that is a lieutenant at Kittinas County Jail in Washington, in the last year, they had a very robust MOUD program, but they were having problems with that, bridging that gap from jail to the community provider. And patients actually making it to the community provider. And then when they introduced peer recovery services, the numbers just escalated astronomically. People felt supported and they were making it to their follow-up appointments back into the community. So they saw such positive results when they started using peer recovery services. And I know this has been a bit of a barrier in several jails that I've worked in. And I'll use Nathan's words, like not throwing any shade or stigma or anything like that. But a lot of peer recovery specialists, they do have some sort of justice involvement in their past. And you know what? That's what makes them so good at that job, because they can speak to it, they can support that person, they've walked in their shoes. But with jails, you have to be or have clearance through the Bureau of Criminal Apprehension. And, they have very stringent security requirements when you go into a jail to work. So it's like, how do we kind of meet in the middle with that? How do we address that? How do we work that? And some jails have looked at it and been like, we're comfortable with this because they're under camera all the time. Or, there's an officer accompanying that person along with that patient. And other jails have said, well, if there hasn't been anything on their record for the last 5 years, we're good with that because they've been successful in their recovery. So I don't think there's a one-size-fits-all answer for that either, but it just takes education on, hey, the big picture is that if we can support people with lived experience, it's going to be beneficial no matter what. So however we can talk through this and find a happy place to meet in the middle. But that is a very common question that I've gotten from jail administration and some clinics and hospitals too.
Well, and I think in a perfect world, Nathan, I hate to say it, but wouldn't it be great if we did things right and there was no need for you in the jails, right? I mean, we got to talk about, it's this whole thing. I just got off this meeting with MDH, with DCRIM, and with all these other things that we're putting these patients, and I'll call them patients and not inmates. We're putting patients in the carceral system that should be bridged other ways by you not in jail, and by your site types of services while they find longitudinal care. And so, really, even though we look at the access to services in jails, it's like, why are we putting them there in the first place, right?
I couldn't agree with you more, Dr. Devine. I think, I was just reflecting the other day about how much the jails have reminded me of the inpatient environment. It's hard to know which direction. Is the inpatient environment reminding me of jail, or is jail reminding me of the inpatient environment? But the power struggles and the way that the system operates, and yes, 100%, the vast majority of folks who I have had the pleasure of working with are there because of a mental health crisis, not really because yes, they broke the law, but they broke the law. There was a million things that led up to that moment, right? That if we had addressed that prior to that happening, they wouldn't be there. And we are trying to build, we it feels like we deinstitutionalized, but then just criminalized and slapped a new name on the wall and called it jail. We should be saying hospital, right?
Yeah.
Yeah.
Well, and when you think about it, it was a while ago when I was in medical school, but I did spend some time at Anoka State Hospital, and there were hundreds of people there who needed had significant mental health needs. And that place is empty now. And where are all those people? They're in our jails, which is exactly where they should not be. So it's a tough situation.
It is. Yeah, absolutely.
There's
Anyone
lots
else
of
want on mute? Go ahead.
laws at a high level.
Alex, question? You look like you're unmuting.
I was just sorry, Nathan, I have things going on. I'm multitasking clinic, but I felt really validated by your talk, because in clinic, I practice like I dually address acute SUD and psychiatric concerns. And it's amazing to me. I have a patient who came to me wanting to get off of methadone, and then lo and behold, she was actually psychotic. And it's just crazy how long they can be so mentally ill and it's not addressed. And then we start to treat that. And then we can, obviously, evidence says the best is to do co-occurring, right? You should say you have to do one then the other. But oh my goodness, there are some really mentally ill people who come through here. And it's incredible to me how they've continued to somehow function. But it's really kept them from, I think, getting to the level, it's kept patients who get paranoid. They don't want to take their Suboxone. They don't want to, it keeps them from fully getting into that state of recovery. And they're also not happy. They're not doing well. They're not able to go out and work. And so it is really complicated. But I appreciate you saying that, because I don't know how much, even in the world of psychiatry, blessed for all the work they do, how much are we doing both of those things together,
Mm-hmm. Yeah, thank you for that, Alex. I appreciate it. I mean, I think I would love to have everybody take an interest in both things, right? Like, not necessarily be a specialist at both things, but, I'm serious. I know there are some people out there, colleagues who I respect, that just don't want to do, they have resistance to one or the other, right? I don't, and yeah, I don't, it's just speaking personally when it comes to, sobriety versus recovery. Like, there were periods of time in my own life where I was sober, but I wouldn't say that was recovery, right? It wasn't until I, got healthy, got happy, built that capital around my life that I saw stability come into play and allowed me to be here talking to all of you wonderful people today, right? But sobriety in and of itself, wouldn't have gotten me here. I needed those other things in place.
Yeah, I think it's pretty interesting the way you kind of frame that, because when we're on forums like this and we get 50, 60, 70, 80 people listening to a talk like this, our perception is that everybody thinks like we do. But the reality is they do not. And I find that at other meetings where people don't think about addiction and mental health needs the same way all of us are thinking about it, and how important it is and how life-changing it can be. I mentioned earlier, I'm actually here up in Lake Winnebagosh with my high school friends, and they're lawyers and engineers, and there's a prosecutor, there's a defense lawyer, there's all these people, and we're having these discussions about these kinds of things, and not everyone sees things the way that we see them, and the importance and the life-changing things. Their perception of my day is that I see people in the throes of chaos all day long. And the reality is 90% of my day and 90% of Alex's day, probably, maybe 80, or in her case, maybe it's 70, is seeing people in recovery doing fabulous with children, with jobs, and they have a difficulty believing that. But my day is often spent with success, as is yours, Nathan, I suspect.
Yeah, I thought William Moyers, I saw a presentation from him many years ago at Hazelden where he showed this a picture of these guys in masks, right? And, where it was anonymity, right? And the message behind that, his message behind that, which has kept it's part of the reason why I actually disclose that I'm in recovery myself today is that, that anonymity, while important, sometimes, the general public doesn't get to see that's the other side that all of us get to see, which is there's this really beautiful side to, addiction and substance use. When somebody gets into recovery and really flourishes in their life like that, that's a miraculous thing. Yeah. And I think that's what really kind of keeps us here, right? Because if it was all suffering, I think we'd all burn out, right? We get to see that other side, which is just, it's beautiful, man.
Yeah, one of my nurses on Monday, I have a patient who finished the peer recovery courses, and he's going to be doing that. And my nurse spent the day helping him look for a job in that, even though he's got a full-time job already. And what a feeling for my nurses to have been with this man through his entire journey, and now he's trying to give back, right? And I think that those are the things that we all bring with us, and we see that make us feel like a group, right? So, yeah.
I think looking at it from another side too is, so I work in behavioral health as well, and as with substance use disorder. And so sometimes treating the psychiatric first will also help get them off of a substance. And that is one of the biggest things that I see with like our psychiatric providers is, okay, whether it's schizophrenia or bipolar or whatever, treating the psychiatric disorder first really helps them get off of whatever else that they've been on, because they're like, oh, I'm not hearing these, I'm not crazy, I'm not this, I'm not that, which is really nice to see as well too. And then they can kind of slowly wean off of whatever they're on as well.
I kind of look at it from the other side of the coin, Sam. I'm like, let's say if they're using fentanyl on a regular basis or opioids, I look at it more from the harm reduction side of, all right, we need to get Suboxone rolling to mitigate withdrawals, take away those cravings, and then, prevent an overdose from occurring potentially. And then kind of work on both at the same time. I don't know. I think everybody is so case by case. You never, it's patient specific. Totally.
Yeah. A lot of patients we see is more like methamphetamine use versus like the opioid use on this side for psychiatry. Obviously the ones that we see for like my substance use are like the opioid use disorder. But more so for psychiatry, we see a lot of like meth use, especially around here. And so I think that's treating some, whether they're hearing voices, whether they're like on something to get rid of like depression, anxiety, treating really their mental health will help them get off of whatever they're on, usually the methamphetamine.
Mm-hmm. Yeah, I'm seeing a lot of methamphetamine use myself. I don't know if that's just the nature of like the corrections work. I mean, if meth is the thing that's going to get you arrested, just as it leads to, can lead to some chaos. But yeah, I mean, that has been, I think, predominant for sure. So.
All right. Other questions for Nathan at all before we kind of wrap things up? I can't say how much we appreciate you coming on. I've been a fan of your path from the get-go. I just thought it was such a fabulous idea. And so, with the work that we do through MDH and the Towns program, and this is something we needed a long time ago. So.
Thanks for the kind words. And it was wonderful to see everybody today. And have a good one. So.
I have a question, quick, Nathan. For counties that are, I don't know if usually counties would approach your path for their services, or if the marketing ever goes the other way and the jails are approached and talked to about the services. I'm just wondering, for those who deny it, if they're denying due to like financial constraints, or like why would anyone see this as a disservice to their community?
It's a complicated question that I think that
simple but complicated, right?
Yeah. No, I mean, I think I'll just tell you what I've run into, right? Like, I think with, and I'll try to be as quick as possible. I know we're, at time here, but it really comes down to stigma, I think, in a lot of ways. You're dealing with administrations and elected officials, and they have different views of what harm reduction should or should not be. Are we sending people out into the community with cookers and needles? What medications do we want to have, in our jail? And then there's also like the corrections officers. I try to understand both sides of it, right? Like there are some individuals who have been arrested for violent crimes, and they're seeing these things and they're reading these things, and there's a perception of this person based on the thing that they have done.
Yep.
And that perception becomes pervasive within the organization. And that, I think, is where sometimes there's resistance, right? Like, how much care do we want to provide? And I think everybody on this call would agree that human beings are human beings. And if we don't want them to reoffend or do the things that they did in the first place, we got to get them the treatment that they need. But that can be hard when you're face to face with whatever that crime was, right? And there becomes the advocacy part of the work that we're doing.
Yep.
I'm going to add on to that, Nathan, because I didn't know this prior to working in corrections, that insurance, all forms, whether it be private or state or whatever, gets suspended when you become incarcerated. So I always wondered, like, why are jails so worried about budget and cost of medications and services? And that's why, because the county takes over paying for those services while someone is incarcerated. So that kind of feeds into it too. Sometimes it's a tough sell from a budget standpoint to integrate additional services that they maybe haven't before. So I think it's the stigma. It's just so multifactorial. It's stigma, it's lack of education, it's money. How are we going to fund programs? It's a lot of different things. So it's just kind of finding, like, what is your county or area passionate about, or what drives them, and kind of tailoring that conversation to maybe what meets their needs and start to build that relationship.
Well, and I think that really leads to the whole thing that I say very frequently in meetings, which is, does this give us a license to give somebody second-class care?
Right.
And I think that's, is it okay to not give them the standard of care because they're incarcerated at the moment for whatever reason? And my answer will always be no, that's not. We wouldn't do that to our animals, or to dogs, cats. So
Alana has her hand up. Alana.
Hi, sorry. I just have a quick question regarding the incarcerated individuals. What are we doing for them after they're being released for their care, if they're receiving Suboxone in the prisons? Do we have like some type of insurance for them to get back on something, or do they get sent out with something like prescriptions when they're released?
Yeah, so there's a lot of variability and misunderstanding, lack of education, silos. So it looks different in every county. So we currently have a grant, and like Nathan said, they work with 6 jails in Minnesota. At Stratus, we work with 11 in total. And in those jails, we do try and teach about release planning aspects as well. So we're releasing with a stock of Suboxone. We're releasing with Narcan. We're trying to make that warm handoff and that follow-up appointment with the community provider to set them up for success. Some of our jails even utilize peer recovery services, which is like the cherry on top of the sundae. I mean, that's amazing. So it looks very different in a lot of places. And prisons, I think there's quite a bit of variability in those as well. So jails and prisons, it's kind of the leadership within the counties dictates a lot how things are going to go and what services are going to be available.
Okay. Yeah, I've seen some clients that I've worked with that they struggle to get their prescriptions after they're being released from the correction facilities. And, that would lead to them to overdose or, and that's my worry. And sometimes the places like Kaishin or things like that, they're kind of booked out months out. So it's hard for them to get in, and, they don't have that go to. I mean, I work at a community clinic, and we do get patients that are in need for like Suboxone or something, and we do have pharmacies that have discounts. But it's just like they should be able to have insurance like a month out, before they get out.
I know.
So
I know.
you guys have any other options for them, like besides like Kaishin or whatever places that do that?
So this would be a scenario where your path would be very helpful if you know that your community provider has a long wait list. So they just really bridge that gap. And the folks that Nathan works with, and he says it way better, but they always say, Jordan, their CEO, always says, like, we're not in the business of keeping patients long term. We really bridge the gap, serve that purpose, and then try and integrate that patient back into their community to get care. So it's just a super cool model that's so helpful.
Okay. I'm just thinking maybe that we should probably get more recovery services, our peer support specialists, like with the probation or the POs, parole officers, because sometimes they lack information on that kind of stuff, on the addiction. And maybe if we can collaborate with them a little bit more, that would be nice.
Yep.
That's all.
And I think there's work at the state level to get people insured. At least I think was it the 1115 waiver?
Yes.
That's I don't know where it's at in the process with everything, but yeah.
And it's always super helpful if the jail is resourced enough to have a navigator or a social worker or an LADC or even a peer recovery specialist or nurse could help with this to get that insurance reinstated to help with that. But it's just comes down to resources and time, money, a lot of different factors. Stigma.
All right. Well, we'll let everybody get going with their day. And Nathan, again, just couldn't be happier to have you on. Great respect for Dr. DeLisi and all the work he does. So I really appreciate you coming and talking. I think from the looks of our chat, everybody else loved it as well. So thanks again.
Right on.
Thank you.
Thank you, everybody. Bye.
All right, everybody. See you next week or 2 weeks. 2 weeks.